You are listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I am your host, Celine Yeager. Each week, I bring you advice from athletes, scientists, researchers, and other experts to help you feel and perform your best, no matter what your hormones are doing. This show is a production of Live Feisty Media. Hello, strong, feisty women. I hope you all are well. So this week, we are going to talk about something we should all probably be talking about a whole lot more: our bones. We talk a lot about brain health and heart health. We talk a whole lot about our symptoms that grab our attention, like raging hot flashes and soaking night sweats and sleepless nights and joint pain. And all that is super important, and we shouldn't stop talking about it. But we absolutely should be talking about our bone health with the same breath, because menopause is a precarious time for bone health, and osteoporosis is a silent condition. Women can lose up to 20% of their spinal bone mass through the menopause transition. 35 to 50% of women, depending on race, have low bone mass by age 50. Your lifetime risk of having a hip fracture is higher than breast cancer, ovarian cancer, and uterine cancer combined. And 30% of women will die within a year of having a hip fracture. The standard recommendation, given all of this, is still to get your bone density scanned when you're 65. F that. If we want to stay strong and active for the at least 30% of our lives that we can live post-menopause, we need to stay on top of our skeletal health. So this week, I sat down with osteoporosis and menopause expert, Dr. Kristi DeSapri, and we talk all about it. She is the founding physician and owner of Bone and Body Women's Health, which is a specialized midlife women's health practice that is focused on consultation and management of perimenopause, menopause, osteoporosis, and fracture prevention and treatment. We talk how to build bone. We talk about how we lose bone and the measures we can take to keep our skeleton strong through and beyond the menopause transition, which again is really a precarious time for skeletal health. We cover a ton of ground here, so stay tuned at the end of this. I summarize the conversation with some action items at the bottom of this conversation. I will also note that the new weight loss drugs like Ozempic are becoming a very important part of this conversation because of their potential to impact negatively on bone and muscle. I'm putting together a separate conversation on those drugs that'll come out in the new year, but it's really something we need to be paying attention to. Okay, before we get to it, as always, check us out and give us a follow at Feisty Menopause on Instagram and Facebook. Sign up for my free weekly newsletter at feistymenopause.com. And if you like the show, kindly head on over to Apple and give us a positive rating and review. I have some really incredible guests coming up, and it helps keep them coming. Finally, a very quick thanks to Oura Ring, which I'm excited about, has come on as a sponsor through the end of the year. If you've listened for any length of time, you know I am an Oura Ring early adopter. I love my Oura Ring, and I have had on plenty of guests, including sleep experts who rave about theirs as well. So you can get 10% off an Oura Ring at ouraring.com/feisty. That will be in the show notes. So you can just click on it. Makes it easy. I just wanted to say thanks, Oura Ring. I've been a big fan for a long time. Okay, enough of me. Let's have a few words about our awesome sponsors and get on with the show. Okay, Kristi. Well, we just had a nice conversation before I hit record, and we are all warmed up for this. And I am very grateful that you reached out to me to have this conversation on bone health, because I've done one show on it, and it was a solid show. But now that I'm 3 years into this and have learned quite a bit myself, I have even more questions, as is often the case. When you start down a path, you get more questions than answers. So thank you for being here, first and foremost.
Thank you, Celine. I love your podcast. I love your guests. I feel honored to be here too.
Oh, excellent. So the first thing I want to talk about, because it makes me insane, is, and I know your focus is on screening and prevention and treatment of osteoporosis, Why, in the name of all that is holy on God's green earth, do we recommend bone density screening at 65 years old? Like everything that I've learned, I'm like, why are we waiting that long?
Yes, you are right. And you're right that we have sometimes more questions than we have answers. But for this one, I have to say the medical guidelines are a little bit antiquated when we look at the internal medicine guidelines. I'm a physician, I'm an internist, but I've practiced a hybrid of internal medicine and gynecology for, since my start of my career, since my fellowship. And, so I sort of straddle both worlds of OBGYN and internal medicine. And unfortunately, the internal medicine guidelines are a little antiquated. They recommend screening bone density starting at age 65, which again corresponds with Medicare age as well, which I think that there's no surprise there. But for many women, and particularly the Menopause Society, which we're both active members, and we were at the exciting conference recently, as well as the American College of OBGYN, really say that we need to take a more risk-based assessment approach, whereas we need to do a fracture risk assessment. That could include just a couple questions about your fracture risk, or could include a screening bone mineral density, which I also shout from the hills is a low radiation, a very simple, easy test that scans both your hip and your spine and sometimes your forearm to assess your bone mineral density, and which is the best surrogate marker we have for bone strength. And that really should be done, that fracture risk assessment should be done at the time of menopause if you have risk factors for bone loss. And guess what? Risk factors for bone loss include aging, being a female, being a cisgender female, I should say, having a family history of osteoporosis, age at menopause. So many women have early surgical menopause or early menopause just earlier than the standard age of 51 and a half in this country. There's so many other risk factors like medications, things like steroid use, aromatase inhibitors, proton pump inhibitors, things like medical history, things like diabetes, type 1 and type 2, patients with thyroid disease, parathyroid disease, rheumatoid arthritis, autoimmune conditions like lupus. These are things that actually affect more women than men, and actually affect more women, both at the time of menopause. We see a lot of uptick in autoimmune conditions. So those are risk factors. Surgical conditions like malabsorptive things, like if you've had any gastric bypass surgery, or we don't think you're absorbing calcium and vitamin D well. So oftentimes it really, when at menopause, we should, or a midlife, I should say, we really need to take an assessment of what is your reproductive history, what's your medical history, your medications, and your family history to determine your fracture risk, because we know that so much bone is, made through our 20s and 30s. We hit a peak bone mass around our 20s and 30s. We kind of hang out there for many women in the perimenopause time. And then at menopause, this is why age at menopause is such an important risk factor, we start to lose bone. So I know that's a long answer to your question, but the reality is screening is happening way too late. We can do screening without a DEXA. We can do a fracture risk assessment, and just a thought about bone health, it would be better than nothing that we're doing currently.
100%. So I have just a couple of follow-ups. So I'm hearing that the fracture risk assessment is sort of like a clinical diagnosis where you're asking a lot of questions, but there was also like, is there a device in there where you can get those other bone mineral densities that you talked about? What is that?
Exactly. So a fracture risk assessment is actually a freely accessible tool. We have a lot of risk calculators, and they answer questions that I just sort of said, putting your age, your weight, your age at menopause, family history, medical things into sort of a diagnostic criteria of what is your risk of a 10-year risk of a hip or spine, a hip or major osteoporosis related fracture. Risk calculators that can be helpful. I don't think that that's the end all be all. I practice clinical medicine. I like to talk and examine my patients. And so those, we need to put that into the mix as well, because we know falls, fracture risk is different than just a one size fits all. And then a DEXA scan, which is a dual energy X-ray absorptiometry, which is basically a glorified X-ray that looks at it's done in a dedicated table, and it has basically a scanner that scans your hip, as both hips as well as your spine, and sometimes a forearm, for your bone mineral density. So it looks at the trabecular components and the cortical components of your long bones, as well as your spine, and really looks at what is the density to date. It's an aerial measurement, so it looks at, again, what is the actual bones that we're looking at, and then gives us something called a T and a Z score, which are basically standard deviations that we have validated the World Health Organization and the NHANES database to look at what is your density compared to someone of a peak bone mass. That's something we call a T score, which again, a standard deviation that looks at your bone mineral density divided by the area, and something called a Z score, which we use in the premenopausal years, where it looks at your bone mineral density compared to someone who's your similar age, race, and sex match. Both are very important. Both tell us some variables about how your bone density is looking compared to age mates, as well as compared to someone of a peak bone mass.
And is DEXA the only machine that you can use for bone mineral density screening?
It's a great question. There is some newer technology that's coming out. There's something called the REMS technology, which is relative energy multispectrometry, which uses an ultrasound instead. This is still kind of like in the development phase. It was actually a technology started in Europe. It is an ultrasound, so it has less radiation, although a DEXA scan is 1/100th of an X-ray and is basically, considered very low level radiation, similar to what you would get on a daily basis walking around. So this might be a technology we might consider, but for now, DEXA is still considered the gold standard for assessment of bone mineral density.
Excellent. So let's go back and talk bones in general and just give like a really brief overview of like the whole osteoblast, osteoclast, and why and when we start breaking down more than we're building up.
Yes. So yes, bone physiology is very confusing to many people, and it really doesn't have to be. I mean, we talked a little bit about being peak bone mass, and how I said, we really build our bone through our 20s and our 30s. And what we're doing there is that we're actually modeling, we're building new bone, we're laying down new bone. We're mineralizing strong bone. This is why we tell our youths to exercise, to weight bear. And actually we should continue to do that, because that actually stimulates bone mineral forming. We know that actually from studying people in space, that they are not forming new bone because they're not doing weight bearing or resistance exercise. When we think about something called remodeling, which is, if you can think about that in your mind, I usually use the analogy of remodeling like your home. Many people know how to, can relate to that. Is remodeling is where we remove old bone and replace it with new bone. And that's how our skeleton, which is again, a very, very, very important part of, what keeps our body up and moving, as well as it protects our internal organs, and is a huge reservoir for things like calcium, phosphorus, other minerals, and essential things for our life and cardiovascular function as well. So when we think about remodeling, we're removing old bone, and we do that, constantly through our life. Actually, 10% of our skeleton remodels every year. So in 10 years, your whole skeleton has remodeled. We know things like trabecular bone in our spine remodels more quickly and more actively. So when we think about menopause and what happens, the osteoblast, the osteoclast, what's happening at the time of menopause is we're losing estrogen and other sex hormones, but primarily estrogen, which has receptors all over our bone and also joints and other places from our head to toe, in our brain and our gut and our cardiac tissue. And when we remove that estrogen, more bone resorption is happening. More osteoclasts are being sort of recruited and are active because there's less estrogen. And so we're losing more bone than we're making. So it's kind of like, again, you just can't keep up with a bone formation. Interestingly, too, estrogen seems, at least in rat studies, to be osteoblastic, meaning it helps form new bones. And so we know that, again, at menopause, we're not forming enough new bone and we're breaking down more bone. And that really leads to this imbalance of bone being formed and thinner, weaker bones. And the definition of osteoporosis, and even its precursor of osteopenia, is weakening or deterioration of the bone tissue, lower bone density, which increases your risk for fractures. And so oftentimes there's a lot of images. You can Google some of these images, and it helps really show, bring osteoporosis to life, because this is a silent condition. You don't walk around saying, hey, I'm at menopause, I'm breaking down my bones and I'm becoming, thinner bone. you say, hey, I have hot flashes. Oh my gosh, I have vaginal dryness. I'm having joint pain. But bones are a silent bone loss. And this is something where it's so important to, that's why we're talking about this here, because many women come to me at the time of menopause or even the years after and are shocked about their diagnosis of osteopenia or osteoporosis. But we know from this clinical literature and from what we're talking about, this is happening with all of us. And actually, thinner women lose more bone density. And it's really appreciated that some women can lose up to 20% of their bone mass in their spine and up to 5 to 7% in their cortical bone mass through the menopause transition. And we absolutely see this. We are studying this actively. We know there's many things we can do to offset the bone loss, which we'll talk about maybe later. But again, it's just important. And this is where, our understanding of biochemical bones really needs to translate into how we use it in clinical medicine to make sure we're capturing bone loss and talking about bone loss, exercise, calcium, vitamin D, and then assessment of bone density at the time of menopause, as we reviewed.
Right. And I have a ton of questions and we'll get through them all. But like before we move on to some of that, like the prevention and what to do and are we all doomed, which I know we're not.
We're not.
Yes. I'm also interested in this concept of elasticity of bones, which is something that came up, I think, when I talked to Avram Blooming for Estrogen Matters. Just understanding that we want our bones to like have a little bit of elasticity, like a tree branch that is bending in the wind as opposed to snapping as soon as a stiff wind hits it. What gives our bones that quality?
Yeah. So, right. So we have a lot of different types of bones in our body. We have trabecular bone and cortical bone. A lot of our long bones, when we look at that, when we look at the density is not the only compartment. And particularly when we're looking at fracture risk, we understand things like bone geometry, bone elasticity, ability to withstand a sideways fall or force. And then something called trabecular bone score, which has become sort of understood that is equally as important or can be equally as important to help us predict fractures, is now part of a complementary part of our bone mineral density. That trabecular bone score looks at the bone mineral quality, is sort of a surrogate marker for microarchitecture inside the spine, looking at things like trabecular number, connectivity, et cetera. And that helps us, number one, to independently predict fracture. Number two, to kind of work with the bone mineral density to help us determine someone's risk of fracture, someone's bone quality. Again, sort of the softer side of bone, if you will, to help us flush out people's fracture risk and really understand, are we moving towards treatment? Do we need to intervene? Or is this someone we could say, okay, yes, things look like they're, status quo and we can follow on the trajectory. A lot of times when we think about hip fractures, which are sort of I always say sort of like the end stage of osteoporosis, is kind of likened to a myocardial infarction or heart attack in cardiovascular. A hip fracture is really, is really the end stage of osteoporosis. And hip fractures, 90% of them occur from a sideways fall. And so when we think about elasticity of bones, things like trying to replicate in the lab something called a finite element analysis, where we're trying to replicate a sideways fall and a sideways pressure bend. A lot of our medications, we study this to see if that would help prevent those forces and help prevent a fall. And you're absolutely right. Mineralization or strengthening of the bone and elasticity of the bone is very important. It's very hard to study, except for what I just said, something, in the lab. We really can't study humans and push them over and hope that they don't fall and fracture. So we do this more in the laboratory setting. But yes, these components of bone, both mineralization as well as elasticity, are very important.
Yeah, well, thank you for that. Let's talk then about turning the tide a little bit on some of this, especially what I'm understanding so far is that it becomes very clear why it's important to build as much in your bone bank as possible before you hit this place, right? Because then you have more to lose, before you hit the danger area, right? Is that sort of what I'm understanding?
I love the analogy of a bone bank, because I think, many of us can understand money. So Exactly. I mean, and sometimes the bone bank is low because of genetics. 70% of our bone mass is inherited. So that's why we ask, does your parent have a a maternal history of a hip fracture, and someone if your mother has had a hip fracture in her 70s, that's actually a risk factor for bone loss and fractures as well. We ask about sisters, we ask about brothers. I mean, we know genetics is a huge role. Reproductive history. We're going to talk later about things like relative energy deficiency in sport, or low energy availability, or the female triad, missing your period for more than 6 months. Those things, again, we know that those can be hallmarks of periods where estrogen was low or deficient, and then that led to less bone being formed or menstrual irregularity. Certain, again, medications. We look at pregnancy. It's very interesting, even though that's a period of amenorrhea, we know, or, lactation, we know that does absolutely contribute to lower bone mineral density. When we study pregnant or lactating women, actually women can lose up to 5 to 10% of their bone mass during those periods. But many of that, because again, we're feeding the skeleton, the calcium is being absorbed into the placenta, and for the growing fetus and skeleton of the fetus, how it's so important again for pregnant and lactating women to obtain enough calcium and vitamin D as well. But most women can rebound from that again and improve their calcium, vitamin D. There is a subset of women who have pregnancy and induced lactation osteoporosis. I see some of those people, and those are people who have potentially other underlying risk factors for osteoporosis. So again, really important to identify all those things that contribute to peak bone mass, because we know at menopause, yes, some women are, preserved and bone mass is strong, and others we're starting at a lower point. So we have to maintain as much as we can to prevent some inevitable bone loss. After the 2 years after the final menstrual period, we know that bone loss slows. I mean, there is some aging, and we know women are now living longer. 60% of women are surviving to over 80. So that's a lot. And so our skeleton has to keep us moving around and functional. So we need to, again, maintain that bone mass, as we talked about in the beginning, so we could continue to do that and live well.
Let's talk about how. Let's talk about like how we get there and what that is. I mean, if I'm coming to you, I do not have a history of it, and I mountain bike, I hit the ground a lot and I seem okay, but can I expect to maintain? Can I gain? Where am I? Like once you get through that menopause transition, what can one expect in the best of situations with all the advice that we're going to give them?
Yeah. So let's first think about statistics. So what's not surprising, and this is from the CDC and NHATES and all of our assessments, is that when we look at bone mineral density and they do a snapshot of people, 20% of women by the age of 50 would have osteoporosis on a DEXA. That does not include women who might have had a low trauma fracture or fracture from a standing height or less, which also makes the diagnosis of osteoporosis. But we know these are very much underdiagnosed and even undertreated. Primarily, many fractures that happen in women in their 40s and 50s could be stress fractures, which is not necessarily an osteoporosis related fracture, but tells us something about their bones, as well as a radius or forearm fracture. Very, very common fractures that are generally treated in the emergency room, outpatient settings, and then women are sent on their way and they heal generally okay. But that again is a Herald fracture. So if I say 20% of women who are, caveat that was 20% of women, it's Caucasian or Asian women who have osteoporosis at age 50 by a DEXA scan, either in their spine or their hip or both. It looks like it's a lower percentage, like 5 to 10% of African-American women. When we think about osteopenia or low bone mass, it's 50% of women by the time that they are 50 would have low bone mass or osteopenia, which is a T-score in the range of -1.1 to -2.4. African-American women, Black women, it's about 35% would have low bone mass or osteopenia. So it's a large numbers of women. And that's basically what I see in my practice. If I see a normal bone density, it's a good day. But I counsel a lot of women regardless. And then when we think about osteoporosis, we know this is woefully undertreated. Actually, 80% of women who sustain a fracture are treated or diagnosed with osteoporosis within a year with our routine pharmacologic therapy. So we have a long way to go. You can see the treatment gap as well as the sort of underappreciation of this condition. So when I see women either with osteoporosis or low bone density at the time of menopause, number one, we do a retrospective look back, which we just talked about. Number two, we think about things like, I always start with lifestyle, and which includes calcium, vitamin D, and exercise. And we can maybe take one of those separately. The other thing which we talked about and we touched on, and we're both members of the Menopause Society, which is again an evidence-based midlife women's health organization that encompasses, gynecologists, internal medicine, subspecialists, really looks at the treatment of midlife women across the spectrum, both looking at cardiovascular risk, diabetes, metabolic issues, bone health, breast health, hormone health. And really, when we think about women who are coming with bone loss, 70% of those women probably have vasomotor symptoms or hot flashes, or have signs like genitourinary syndrome of menopause, which is vaginal dryness, painful intercourse, recurrent urinary tract infections. And then the other sort of, I call them sort of like the fringe menopausal symptoms, which many women have: sleep disturbance, maybe related to hot flashes, maybe not. Things like joint pains, things like mood or anxiety or cognitive concerns. So for women who are less than age 60, and again, remember, we just talked about these are generally women at the menopause transition. So I would say 100% of them are less than age 60 and less than 10 years since the menopause transition. We know that hormone therapy, by level 1 evidence, which is supported across the board by all medical societies, we know that hormone therapy is FDA approved for prevention of osteoporosis. And we know from the Women's Health Initiative study, 27,000 women studied from the age of 50 to 79, that that hormone therapy at standard doses also reduces the risk of hip, spine, and non-vertebral fractures. So again, when we're trying to offset bone loss, hormone therapy for the right person at the right time with the right doses without any contraindications, and we can review those separately. Really, that is something that I counsel on, because again, it's going to help with their symptoms, their outward symptoms, and it's going to help with their inward symptoms, which is their bones, which they didn't feel, but they're coming to me for anyway. And so that is something that's really important. We know that calcium, as we go through menopause, it's like a double hit. We actually have more urinary calcium that's excreted because we're upticking the osteoclast, which we're breaking down more bones. And so when we do break down more bone, more of that calcium gets leached out into the urine, which is, not fair. So we need to be better about calcium intake. I would say also 75% of the women that I see are not taking in enough calcium. They did not know they needed enough that calcium. They say they're lactose intolerant, or they think that's going to cause them to increase their cholesterol or gain weight. There's so many calcium options now here in the United States that we have, both dairy and non-dairy sources, as well as supplementation, which again is supplements to the diet. I really don't believe in 100% of supplementation for anything. So we talk about those things. Vitamin D helps absorb calcium. And then, the big E, the big exercise discussion.
Let's talk about the calcium supplementation there, because it's become a little bit fraught with controversy over the years, and the research, just you tell me like what you think about calcium supplementation, because you're hearing this like heart disease murmurs over here and kidney stones, and I think people have become a little afraid of calcium supplementations in some circles. So I'm curious what your thoughts on that are.
Yeah, absolutely. So, when we think about supplementation, we first need to understand, so what is the recommended daily allowance? And remember that when we think about these things, the recommended daily allowance is generally set by, government agencies, the Institutes of Medicine, et cetera. And these are, for the community dwelling average, individual, whoever that is. And generally what's recommended for, postmenopausal females is 1,200 milligrams of elemental calcium daily. So when we think about that, there's lots of ways we can get that. Generally, you need to educate yourself, and a lot of clinicians should be able to educate you on calcium intake. There's some calculators that are freely available to understand how much calcium is in a glass of milk. So generally, like a glass of dairy milk, as well as even non-dairy milk, fortified milk, whether that be almond milk, soy milk, oat milk, things like that. There's generally anywhere from 300 to 450, even upwards milligrams of calcium for an 8-ounce glass of milk. Not some of my patients say, oh, I just like put a tablespoon in my coffee. Well, that's not going to get you where you need to go. And so generally, when you take a dietary inventory and say, okay, what are you doing for calcium? And I always say, calcium has most calcium rich foods also have a lot of good protein, which is, we know that is very important for bone health, as well as maintaining muscle mass, as well as weight management. So getting enough calcium gives you generally fortified foods generally gives you enough protein as well, and also important calories that we need for the day. And then in terms of supplementation, so whatever you need to make up in supplementation, whether you need 1,200 milligrams or you need more because you have malabsorptive issues, or you need a certain type of calcium, because as you mentioned, some calcium contributes to kidney stones. And we know that excessive calcium supplementation leads to things like kidney stones, leads to things like constipation. I mean, so many women I see, we have to battle these two things. So we work on treating both together. So, again, calcium supplementation at the right doses. In many studies, including many meta-analysis going back to the early 2000s, we know that appropriate calcium doses, and I think that includes supplementation, really offsets bone loss, maintains bone mineral density. It's very hard to study fracture risk, but there has been some meta-analysis showing that appropriate calcium supplementation with at least 1,000 milligrams of calcium slightly decreased the risk of all-cause fractures in postmenopausal women. We know from the Women's Health Initiative study, again, the largest study that we have, definitely has some misgivings, but it did help us in osteoporosis to really point to the fact that women who took 1,200 milligrams of calcium reduced their risk of osteoporosis related fractures more than women who took less calcium. So we know that calcium helps the medications we use for osteoporosis work better as well, because again, it mineralizes bone. And now that you're all experts on bone metabolism, when we break down bone or we remodel, we lose the calciums that we need to replace when we're going to form that new strong bone. So very important, 99% of our calcium is stored in the skeleton, and we need that for other things, like I mentioned as well, cardiovascular, nerve conduction, etc. So again, calcium, we can't just say not important or so controversial. Where the controversy comes is that when people take excessive amounts of calcium, and we know that calcium supplementation likely increases the blood calcium sort of more dramatically. There's been some very few studies looking at excessive calcium supplementation causing cardiovascular calcification. We're now talking more about cardiovascular calcification because we can study that with something called a calcium score in the heart, but that doesn't necessarily mean that calcium and supplements are related to coronary artery calcification. And that was really one small study that showed that. Many of the lion's share of the research and really do not show that calcium at appropriate doses cause coronary artery calcification. So it's important not to stop your calcium. We can treat both cardiovascular disease and osteoporosis because both, are equally important.
So if I can boil that down very succinctly for people, you should maybe do a few days of assessment of what your calcium intake looks like. Get an idea. There are many different food things that you can plug in what you're eating, and it will break it down. And then make sure that you cover your bases by getting up to that 1,200 number. Is that fair?
That is fair. And for some women, they need more. Some women might need, less if they're saying, okay, I get so constipated with calcium, 1,000 to 1,200. Some women with malabsorptive things, like I see a lot of women with celiac, with inflammatory bowel disease like Crohn's or ulcerative colitis, or women who've undergone gastric bypass, they need even more, closer to like 1,500 sometimes. And so, because we know most of the calcium is absorbed in the small intestine. So again, and then women who are on steroids, actually even glucocorticoids, we know that unfortunately that shuts down sort of the barrier of absorption too. So they might need more calcium. So again, that's where it comes, like it's a little bit of a nuanced discussion, and it really is individualized. Some women have lactose intolerant. Okay, well, that doesn't mean no milk, right? There's so many good options now that we have for fortification.
Excellent. Moving on to sort of a broader picture of diet. I mean, I guess I should ask about supplementation with vitamin D before we do that.
Mhm.
Vitamin D is sort of the golden child of supplements at the moment. So lots of people take it for lots of different reasons. Do you recommend just supplementing with that as a matter of course?
Yeah, so you're absolutely right. I mean, vitamin D, I mean, we talked about this a little too, is that everyone, no supplement is going to become like the end all be all of any treatment or, any lifestyle. So vitamin D, has been studied many different ways. And what we know again from, recommended daily allowances for postmenopausal women, around 800 to 1,000 international units of vitamin D3, which seems to be a better absorbed than potentially vitamin D2. If you're not deficient, seems to be appropriate. How do we know you're not deficient? Generally, most bone health specialists as well as internists, gynecologists should be checking a vitamin D, a 25 hydroxy vitamin D level, which tells us sort of the vitamin D status is in your body and bones. And generally, deficiencies less than either 20 to 30, depending on who you're asking. Generally, vitamin D levels between 40 and 60 to maybe 70 nanograms per milliliter is what's recommended. Excessive vitamin D can just cause sometimes actually calcium to be excessively high. We know vitamin D is also stored in fat tissues. So we don't need whopping doses of vitamin D. We know vitamin D might help, with some immune status, and we know that from the COVID pandemic. But we've looked at large scale studies such as the VITAL study, which was out of Harvard. Routine doses of 2,000 international units of vitamin D3 did not reduce the risk of all cause fractures. It also didn't reduce the risk of all cause mortality or cancer or cancers. And so again, pointing to the fact that one supplement isn't going to do everything for you. I mean, some women need 800, some women need 1,000, some women need 5,000. If you're deficient, we need to sort of fill that tank back up. And so you maintain. Vitamin D is a prohormone. It is absorbed in the skin, but many of us don't live in colder latitudes or are not outside getting vitamin D every single day or putting on sunscreen with UVA and UVB. So again, most vitamin D can be supplemented. Check your supplements. A lot of multivitamins include vitamin D. A lot of, calcium supplements include vitamin D. So sometimes you might be getting what you already need without taking anything supplemental. But again, an individualized look at that blood level. And you have to be consistent with calcium and vitamin D. I have patients who say, yeah, that one day when I'm in my car, I pop the vitamins that are there. Or I forget because I'm so tired at the end of the night, I fall into bed. Well, you need to be consistent with the supplements too. That's really, really important.
Excellent. So now let's talk about your diet more broadly. You mentioned the importance of protein. I got to tell you, I'm very concerned about my audience who has been constantly dieting throughout their whole life. And it's probably, and I hear so many people restricting. And I read some of the literature on keto and low carb and what the relationship of low energy availability to bones. And I just find it concerning. And I'm wondering what your experience is.
Yeah. So my experience, with relative energy deficiency syndrome in sport, or the female athlete triad, and low energy availability, is again a constellation of menstrual irregularity, amenorrhea. For bone health, particularly, they usually come to me for that, are things like stress fractures, osteoporosis, poor healing. Again, when we think about stress fractures, generally stress fractures of the tibial plateau, the femoral neck. Ankle, recurrent feet, metatarsal fractures, things like that. So yes, I mean, generally those are my, premenopausal women, but sometimes also, postmenopausal women. And there's, again, this is sort of a subset of sports medicine more than, routine gynecology and internal medicine, which I think is unfortunate, because I think many of us, in the general population see these women and are not sure how to, treat them. This is generally a very complex interplay of specialists, right? We need both gynecologists, we need nutritionists, we need sports medicine folks. A lot of these times, these people are high, elite athletes or high performing athletes. I see a lot of collegiate athletes as well, sometimes with these symptoms. So again, it's working them on nutrition, getting adequate caloric intake to oftentimes and fat intake to often restore the menstrual cycle. Things like working on training, so cross training versus so much running or aerobic training that needs to be done. Again, working with a trainer, that is not me, but working with someone who can help with them with that. Restoring menses, this is also a whole like hour-long conversation, but we know that oral contraceptive pills are not generally recommended just to restore menses. We know that that actually decreases the osteoblasts and decreases the IGF, which is a certain factor. I know I'm getting kind of nerdy and sciencey here, but and so we know that those generally are not the recommended treatment for someone with a low energy availability or female triad, and we should be using more things like transdermal estrogen and trying to restore the menstrual cycle if we can. And then treating stress fractures and fractures is, again, adequate calcium, vitamin D. And then sometimes some of these patients do end up going on osteoporosis related medications to boost or build up their bone mass. Also thinking about things like, again, how we train, return to run programs. This is a long process for a lot of these women.
Well, and my audience is older. I mean, there are women who are in perimenopause or beyond. Many of them have IUDs. Many of them have periods that are all over the place. They are getting stress fractures. They are restricting. They are in LEA. They don't know that they're in LEA because LEA often mirrors what they're experiencing in perimenopause, right? So, I mean, I find them an even more precarious group because they are out doing, I just was at Ironman World Championships. I mean,
yeah, I saw your pictures.
Huge number of that field are 40 plus women. I'd say the vast majority of them. We're out there. I mean, even if they don't have pro contracts. Right. And I feel like they're slipping through the cracks in this conversation, and it concerns me.
And it goes to the point that we talked about even from the outset, that we're losing our bone mass. Just because you hit menopause, the bone loss doesn't just like drop overnight, just like how people, menopause isn't just a one-day event, right? We're living in the menopausal years. So we know that, FSH is starting to increase, estradiol is starting to go down. All these things are happening in the perimenopause. And then calcium is, we're not thinking about calcium. And then look at those women in their 40s, right? They're multitasking like amazing people, right? Like they're mothers, they're community members, they're working, you're doing all these things, and they're exercising at the elite level. I mean, this is crazy. So again, appropriate fueling, thinking about hormonal health, thinking about calcium intake, all these things, very, very important. Vitamin D, building their bones, and then understanding a bone mineral density, also important as well, right? So maybe those people, if their concern, should be obtaining a DEXA, early if they've had a stress fracture, if they have a family history, to understand what their bones look like. I think we don't have a lot of great answers, in terms of pharmacology management. Again, like I mentioned, we kind of see the end of these things, but we don't really know how to treat in the middle, except for, again, calcium, vitamin D, know your risk. And I think that we need more in this, sports arena for women, because more women are contributing and continuing.
I want to quickly double click on the stress fracture and stress reaction piece. If women are experiencing that, is that a red flag for bone health?
Absolutely. I mean, absolutely. I mean, stress fractures, what I see is generally recurrent or stress reaction. Yes. I mean, these are, generally maybe repetitive emotions or exercise or overstressing the bone in a certain way. Some of that, again, could be due to physiology, could be due to your hip axis length, could be due to your running pattern, could be due to your feet. I mean, we know that some people need, specialized orthotics, or need to, strengthen certain areas, do, quadricep training, do certain physical therapy to, not to overtrain or overstress. This isn't sort of the mainstay of people who train for marathons, triathlons, just like you do. So, that's not so much my world, but yes, I mean, that means there's something going on, right? Like this is the end stage. Something is going on that we need to kind of back up and look at all these different pieces: nutrition, bone health, hormonal, mediations, all of these things.
And let's talk about that exercise piece, which is very important and last but not least here, because a lot of these women, obviously they are running a marathon or they're doing all this thing. But my understanding is, even though running is quote unquote impact, that does not necessarily protect you from these bone losses that we're talking about, correct? I mean, I hear a lot about multi-directional and strength training. Like, what does the exercise component look like when you're talking about that bone health piece?
So again, I'm trained as a medical doctor. As what I've learned, is basically self-taught or taught from, physical therapists, trainers, people in the, Pilates, exercise world, books that I've read. We don't get trained on this as medical doctors. That's why the prescription for exercise, when you go to maybe an endocrinologist or rheumatologist, many of these people are my close friends and colleagues or gynecologists. It's sort of like, well, like, you should just do some walking or you should lift some weights. But again, for many women, they're either, either doing a lot or they're not doing anything, or they're just so confused and they're stuck in the middle. And so I see a lot of women who come to me with osteoporosis and now they're sort of walking on eggshells. They're like, can I even walk? What about skiing? What about rollerblading? What about Zumba? What about my Pilates or yoga? So there's so many confusing mixed messages out there and disinformation. And I think it's because there's just it's very hard to study exercise. And also that's not getting out into the medical community. So what we do know though, and again, from limited studies, is that you really should, right? There's many different options for exercise. So things like aerobic exercise, which is like you're running, which is cycling, which is, classes, which is, racket sports. Those are, good for, generally everything. I always say those are good for the brain, the heart, the bones, your mood, all these things. So you're adding in those, we know generally, again, what's recommended from the powers that be for the average woman, 150 minutes of aerobic exercise weekly is what's recommended. We heard from the Menopause conference that more like 200 minutes a week is recommended for weight maintenance. My patients balk at that because that's an hour, 5 days a week. But, that is, most likely what is, going to help us prevent, number one, weight gain, and number two, help us, build muscle and keep up our aerobic strength, which is good for cardiovascular, bone, and et cetera, probably breast health as well. When we think about things like resistance exercise, also, what does that even mean? Using your own body weight can be resistance. So things like yoga, Pilates, things like using resistance bands, using weights, but that is so individualized. I can't tell an 80-year-old to go lift a 10-pound weight. She will look at me like, what she is going to think about using resistance bands or working with a trainer, or I recommend some, YouTube videos or personalized things that she can do. Versus a 50-year-old woman, I say, there is no reason that you cannot lift a 10-pound weight or more, depending on where you're starting from. Generally, resistance exercises 2 times a week for at least 15 to 20 minutes, doing a sort of probably a total body circuit is helpful. Again, maintaining muscle mass around the bones, as well as preventing fractures. So we know that when you strengthen your hip flexors and the muscles around your hips, that prevents falls, that prevents muscle loss, which we think of as sarcopenia, muscle loss with loss of muscle function. So working on resistance exercise can help. And number one, again, that helps again with metabolic. We know that, when women go through menopause, we're more of that muscle tissue is getting converted to adipose or fat tissue, causing insulin resistance. So the more resistance exercise, the more muscle mass you have, the stronger you're going to feel, the better you're going to feel, as well as we're going to have less insulin resistance and strengthen your bones. So those things are all kind of like a double, really a double benefit. The one that gets forgotten about is posture and balance. I assess this in every single one of my patients, no matter if they're 35 or 85, and working on balance, making sure you can balance on one foot for 20 to 30 seconds. If that's too simple, challenge your balance. There's many other ways. Doing a sit to stand as many times as you can in a minute, doing a get up and go test for some women who, again, have maybe, are have more advanced osteoporosis or at high fall risk. And then again, working with allied, health professionals, physical therapists, trainers, et cetera, that can help patients, meet those goals consistently, right? So it's like doing it every day, doing it 2 to 3 times a week. So it seems like a burden, but, if we can break it down to aerobic exercise with some resistance, with posture and balance, and some exercises include all of those things, at least consistently a couple times a week, that really does, again, put women in a very good position. And out of that fear-based, what do I do if I have osteoporosis, or what can I do to, offset bone loss and offset muscle loss? And by the way, I want to offset, weight gain and help my metabolism the best way that I can.
Yeah. And this audience is not burdened by telling them to exercise.
Yeah.
I mean, we have a very active
Yes.
audience.
Yeah.
But
Hit
it
play,
is
not
interesting.
pause. Yes.
Yeah. Well, and they're very active. I mean, it's interesting
Yeah.
though, because I had Juliette Starrett on the show, and one of the things that she talked about, which is true, there are people listening here who can run a marathon but can't deadlift like whatever, or can deadlift 200 pounds but can't stand on one leg and balance. So I think that they're more in danger of getting imbalanced in one of those directions and not being more 360 degrees strong, in a way that might help their bone health as well.
Right. Absolutely. I mean, I heard it from someone else and I love this phrase, training for life, right? So it is. It's like the balance piece is important because we all lose our proprioception. Medications change that, muscle mass changes that, just day-to-day fluid shifts can change that. Posture, again, not only affects, I mean, posture differences can sometimes be vertebral fractures or spine fractures where we, have asymptomatic height loss, and that can be a sign of actually clinical osteoporosis. So again, measuring height is so important, but posture becomes important, not just for vanity's sake, but also that can contribute to like our lungs feeling compressed. So a lot of our organs, constipation, and then we fall more often if we're not looking in front of us, but looking down at our feet. So again, all levels of age. And I think you're so right when you say this, your audience, I mean, it really should be looked at by decades or times in life, right? So we talked about peak bone mass, and women should be talked about that in their 20s and 30s, not just drinking soda and having supplements and smoking and, trying to maintain a low body mass, but really, again, feeling strong through those years, in our 30s and 40s, reproductive years. Okay, making sure that, again, we're pregnant, lactating, we're getting enough calcium, vitamin D, continue to exercise, thinking about our period as sort of a vital sign, our menstrual cycle is a vital sign. Then looking to our 40s again, we're starting to hit the stride of perimenopause. And this is general, I'm saying generally because we know perimenopause can start in our 30s, and we know some women, menopause doesn't, their final menstrual period doesn't end until 55, but we know 95% of women are through, have the menopause transition or 12 months without a period between 45 and 55. And then again, that menopause midlife period that we just talked about, really thinking about bone health and capturing what your bone health has been and what it's going to look like for the future. Because as we know from statistics time and time again, 30 to 40% of women are living their, or women are spending 30 to 40% of their lives in the postmenopausal years, right? Which we want to stay fracture free. Many of your patients like mine want to stay strong, live independently, and really understand their risk of certain conditions moving forward so they can live optimally.
So I'd like to, before I hit record, you shared a story about a woman who sort of turned things around for herself. And I hear from so many women who are like, they even hear they have osteopenia and they're like, is that a slippery slope to osteoporosis? Is this done? I think we've explained that it's not, but I'd love for you to share that story about that woman. I think she was 58 even, and was able to help sort of her bone health.
Absolutely. Yeah. So often, again, in my consultative practice, I see women with either menopausal symptoms or bone loss, or come to me, wanting a DEXA scan or evaluation, understanding and treatment of that scan. And so, as I mentioned in the outset, I, see many women who are in that, 50 to 60-year-old category who have bone loss, whether they have osteoporosis, like the statistics I shared, or osteopenia. And there are a lot of things that we can do. And so this one was 58. She had never been counseled on anything. She had her first initial DEXA at 57 and had shown, it showed osteoporosis, unlike, many that we see. And she was a Caucasian thin female exerciser, thought that she was, very, educated about her health. And very confused and upset by the diagnosis. And we talked about all the treatment options. And again, she had symptoms of weight gain and sleeplessness, etc. And so tried a low dose hormone therapy after counseling. And a year later did her DEXA scan, and her bone mineral density is improved. When we think about hormone therapy, we're not going to improve our DEXA 10 to 20% like some of the medications might do, but offset the bone loss from the Women's Health Initiative study, 5 to 7% of bone loss can be prevented with standard doses of hormone therapy over 3 to 5 years. And her bone mineral density improved, both numbers in the spine and the hip. Again, we know she's 58, so she's a relatively low risk for fracture. She's been working on her balance, and we see changes. And she got on appropriate calcium and really thoughtful more about that. And again, sleeping better, feeling better. And I asked her, "How are you sleeping?" She said, "Oh, I sleep fine." I said, "Oh, well, last year you didn't." She said, "I don't remember that." It's amazing. It's amazing when people feel well, they're like, they don't remember. And I think, well, we take detailed notes, so we remember. But again, this is an example. It doesn't have to be earth shattering. These small changes can actually make a big difference, both internally as well as externally.
And then those other medications, that's something that you would work with, like a Fosamax and all of that. Those are medications you would work with your doctor, right? To if you
Yeah,
need
so
them.
those are right. So though there is I mean, that's a, yeah, we can come back and talk about all of those.
Yeah.
That is exciting. There is so many treatment options. This is what I do day in and day out, for treatment of osteoporosis. Again, we're not doing a great job at identifying women at risk, and then we're not doing a great job, for many reasons that both include medical factors as well as media factors and patient factors at diagnosing and then treating osteoporosis with women who are at high risk for fracture. Those have had fractures, those have T-scores of minus 2.5 or lower. So there are mainstay of medications that both prevent osteoporosis, then treat osteoporosis, both bone building medicines, which we call osteoanabolic medications, and then medicines that reduce bone loss called anti-resorptive medications, hormone therapy being one of them, raloxifene being some of them, Duovi would be another one, and then other or alendronate, bisphosphonates, IV options, etc. So that really also becomes like a nuanced, individualized discussion. But we know for many women, these FDA-approved, safe and effective medications reduce fracture risk by 40 to up to even 80%, depending on the treatment site and things. So again, really good options both for prevention of fractures and then treatment of osteoporosis.
And I want to drive home how important this all is, because I don't think like people really don't understand. Like when you talk about breaking a hip, you're talking about a lot of people, that's the end of the line, right? Like they don't recover and they die. Correct? I mean,
You bet.
yeah.
Yeah, so again, we talked about osteoporosis related hip fractures, which I really feel like we failed women when I see those. And generally those are happening in our women in our 70s and 80s. And remember, 60% of women are living longer than 80. So these things are happening. You're actually more likely to have a hip fracture than you are. Your lifetime risk of a hip fracture is more than breast cancer, ovarian cancer, and uterine cancer combined. So hip fractures are common, and they carry a significant morbidity and mortality. So we know from the Bone Health and Osteoporosis Foundation, and they've looked at a lot of data over the age of women over the age of 65 and Medicare data. 30% of women will die within a year of having a hip fracture, both from the hip fracture itself and then from comorbidities they might have had beforehand, or infection, blood clot. And then 20% will not live or walk independently again, which really again changes the trajectory of your life and freedom. And a lot of women, when I'm seeing in their 70s, 80s, that is their goal. Their goal is to, again, live and work. A lot of these women are still working in their communities and giving back in so many ways independently. And so we really need to think about, again, treating fractures from a holistic standpoint. Sure, medications are important, exercise is important, fall risk is important. And again, really thinking about hip fractures as life-changing, as you mentioned.
Well, I really appreciate your time, Kristi. I feel like we've covered a lot of ground here. Is there anything that we haven't talked about that you wanted to leave our audience with?
Yeah, I think we have really gone from the beginnings of bone mass to menopause, which I think we've really highlighted here, which I think is just needs to be really augmented in both the medical world as well as, patients understanding about needing this. They don't just need their pap smears and their cervical exams and their mammograms every year, but we need to start moving beyond just like bikini medicine and thinking about, bone health, and muscle and fall risk and things like that are going to really impact our years in the post-menopause. I think, yeah, I just think this is such a great forum, and I appreciate you opening it up to this topic.
Thanks so much. I'm gonna hit. Okay, that's our show. And as promised, I would like to summarize a few of the points here at the bottom of this conversation, because we covered a lot of ground. If you are hearing my voice right now and you have not already, you need to do an assessment of your bone health and or fracture risk. There are online calculators you can use as a good starting point. I've checked them out. They're very useful. I'll put a link to those in the show notes. You can also get a DEXA scan to measure your bone density. You can find that at any local healthcare facility. I'll put a link to search for that in the show notes as well. Insurance may or may not cover it if you're under 65, but I looked that up. They are not very expensive. They average about $125, and your bone health is super, super important. There is a strong genetic component to osteoporosis, so knowing your family history, if possible, helps a lot. If you are at risk or have low bone density, definitely take a look at hormone therapy. Hormone therapy for menopause or hormone replacement therapy, HRT, MHT, whatever you call it, is FDA approved for the prevention of osteoporosis. If you are not a candidate for hormone therapy, no panic. There are other great options for you. We did not get into all of the pharmaceutical interventions because, as she mentions in the show, that could be a whole separate show, and it's so individualized. It's something to work with your healthcare provider, but there are many options. Please utilize them. Most women do not. And again, bone health is super important. Make sure you eat enough to fuel your activity. I have talked about low energy availability a billion times over the past 3 years. It's really important, and many of us slip into it because we don't fuel enough for both our activity and our lives. It sets the stage for bone loss. So make sure you eat enough and you get enough protein and carbohydrates. It's important. Speaking of nutrition, get at least 1,200 milligrams of calcium. Try to get it from food first. There's tons of fortified foods out there, and then make up the difference if there is one with supplements. And you can take 800 to 1,000 international units IUs of vitamin D3 as well to supplement your bone health. Perform regular resistance training. We talk all about that on this show. And do some jumping, just 10 to 20 jumps a day. It doesn't have to be giant box jumps. Just standing jumps is scientifically shown to help build bone. Again, you're really only as strong as your skeleton, so stay on top of building those bones. All right. So for next week, I sit down with Christine Yu, author of Up to Speed, and we sit down and dive into the state of research on menopausal women right now and why we're all so freaking confused half the time. It's a good one. So come on back for that. And until then, as always, stay feisty. You've been listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I'm your host, Celine Yeager. The show is edited and produced by the strong, talented, and amazing women at Live Feisty Media. Follow us on social media at Feisty Menopause, and please help us spread the word. Screenshot and share this episode on your social media channels with the tag @FeistyMenopause. Share the show with your friends. And please subscribe, like, review, and rate this show wherever you get your podcasts. Word of mouth and good reviews make it easier for other listeners to find. Thanks for listening, and as always, stay feisty.